Good afternoon. Welcome back. My goodness, we have a full studio today. Thank you so much for being here. My name is Michael Boylan, President and CEO of WJCT Public Broadcasting. We appreciate your being here today. A couple of items. Number one, before I forget, because I always do, if you have a cell phone, I'd ask you to please put it on vibrate or turn it off if you can, so that we don't have any interruptions and everybody gives you that ugly stare that you get when your phone goes off and you have to go, oh, and get to your pocket or purse and turn it off. So avoid that embarrassment if you can. I wanted to, first of all, a lot of folks have been asking the question. As you probably know, on the radio last week, we had our one-day radio drive, and our goal was to raise $100,000. And we raised over $87,000 in one day. And I got to tell you, we're really proud of that. So thank you for your support. But it's not too late to call 353-9528. The scary part about that, about $87,000, that's about 6 days of our operating expenses for a given year. So we raise money in a lot of different ways, and that's one of them. But we do focus those dollars on providing you with the programming you enjoy on 89.9, so thank you for that. A couple of items. You have on your tables the save the date for the Speaking of Women's Health event coming up in August. I think this is our 12th, if I'm not mistaken. Gets better every year. And I'm really proud from the vantage point that not every market, for those of you who are longtime supporters of Speaking of Women's Health, it used to be a national partnership that we worked with, but the national organization went away, but we continued to produce this event because we know what value it has for our community. And frankly, it wouldn't be possible without the good support of Baptist Health in that process. And we're very pleased to continue the relationship with Baptist Health and the work that they do in the outreach and education in the community. We obviously have parallel tracks in that regard. So I wanted to say a special thank you to Baptist Health. And again, partners with today, the Jacksonville Orthopaedic Institute. And I want to mention, not only do we have this day, and I'm sure you're going to learn everything you want to know about knees today, but in the event that you don't, our next event in May 16th, is going to be with from Dr. Lucie is going to be speaking on this as well, and a different focus, I assume, in that conversation. So if today it's going to be worthwhile to you, you may have friends who have knees, and we're going to do deep knee bends here in just a couple of minutes just to get the doctor some work before he leaves today, so there's a return on his time. Take a look at there's the card out front in the lobby as you exit to pick up one of those postcards for our next event. It will not be held at the studios here. We're taking it on the road the next time to encourage and involve other participants. I think this is on the north side, if my memory serves me correctly. All righty. Well, again, thank you so much for your support, continued watching of WJCT television and listening to our radio stations. We're really proud to be, as I shared with our board members last week about the success of our campaign, I stressed upon him the importance of us being relevant to this community, and events like this are typical to that relevance. But I think we've gone past relevant for some people to important, and I think that's evidenced by your support, so I continue to thank that. A big part of our success, of course, is the introduction a couple of years ago of our First Coast Connect program, and most people know very well the voice and now the face of Melissa Ross, the host of that program. So please welcome her as she introduces our guest speaker today.
Thanks, Michael. Thanks for being here. Full house. Good to see you all. How many listened to 89.9? All right. Well, then you have listened to First Coast Connect, I hope. Every Friday we do a segment called Weekend Warriors, sponsored by JOI, the Jacksonville Orthopaedic Institute, and we talk about things like knee pain and fitness and all manner of issues related to people who want this information. So I'm pleased today, alongside Baptist Health, to present Dr. Stephen Crenshaw. He's been a guest on our program several times. Maybe you've heard him. Dr. Crenshaw received his medical degree from the University of Miami. He completed his orthopedic surgery residency at Madigan Army Medical Center, where he completed 10 years of service with the U.S. Army. This is an interesting bio. He finished as chief of the orthopedic surgery service at Darnell Army Hospital at Fort Hood, Texas. Today, Dr. Crenshaw is the chair of the Department of Orthopedic Surgery at Downtown Baptist Medical Center. He is also the team doctor for the Jaguars and JU Athletics. You're not doing very much, are you? Not very busy at all. He is a board-certified orthopedic surgeon, and he's one of only a few in Northeast Florida with a subspecialty in orthopedic sports medicine. So there might be some athletes in the audience today that he can speak to some of your concerns. Dr. Crenshaw practices at Jacksonville Orthopaedic Insititute San Marco. That's an affiliate of Baptist Health. So please join me in welcoming Dr. Stephen Crenshaw.
Hopefully this mic works okay. Can you hear me? Do I need to use this? We're good? Well, thank you, Melissa, for that introduction, and I want to thank everybody for coming out today in the middle of the day, in the middle of the week, to hear this talk. What I want to do today is to bring to you something new about something old. We're all familiar with joint disease. As we age, we deal with it every day, and this is going to be a little new information presented to something that has been around as long as we have been around. So to start the discussion, the title of this is New Options for Knee Pain. It's regarding robotic or robot-assisted partial knee resurfacing. And this is relatively new technology, very new technology to us. At Downtown Baptist Hospital, we have just acquired a robot surgical unit that we've now had for about 4 months, and we are starting to use this more and more and learning more about what the advantages of this technology brings to us as surgeons and really to the patient and the individual who it is applied to. So first we're just going to start in general with what is osteoarthritis. Arthritis is probably confused by many people as is it age-related, is it disease-related, is it trauma-related, is it infection-related, and it could be any of those. So arthritis in and of itself is not osteoarthritis, although osteoarthritis is a form of arthritis. And there's probably about 100 forms of different types of arthritis that can affect joints. And osteoarthritis is the most common. This is the degenerative joint disease or age-related disease that we're all familiar with. And it most commonly affects, at least in the lower extremities, the knee. So it's the most common form of arthritis, and it leads to more disability worldwide. So this is a problem. This is a problem we all have to deal with as we get older, particularly as our population age increases from decade to decade. The statistics right now, and this is changing, but 46% of the people will develop knee arthritis in the course of their lifetime. I suspect that number might even be higher. When we talk about osteoarthritis, we really look at it, particularly as we'll get into this robotic applied technology, but we really look at it as a progression of a disease. You don't wake up with an end-stage, profoundly arthritic joint. It evolves to that. And one of the important things that we're finding is that this early stage, or this mild disease, which happens as early as in your 30s or 40s, is the precursor to that disease that really cripples you later in life. And for that reason, the focus on this early stage has always been, to not only treat the symptoms, but to try to see if there's a way that we can slow the ultimate devastation to the joint and change the outcomes for that years later that's coming. In the early age stages, this is many times a sports injury. We see a lot of that in football, other sports, defects or loss of cartilage, usually due to damage. But it also happens spontaneously. Some people, for either genetic reasons or maybe some childhood issue where they have bow-legged or very knock-kneed, may go on and develop this early stage of disease. But the next stage, the mid-range or mid-stage disease, which is where it starts to become a little more progressive. It's starting to move. So in this early stage of disease, it may be isolated to one part of the knee. In this picture here, it's showing it on the medial or the inner side of the knee. But later it may be moving over to the top of the knee or the front of the knee, which is where your kneecap is, but still sparing the outside of the knee. And this is still an age or a stage where the other changes have not yet occurred. You don't see a lot of bone spurs, you don't see contractures, you don't see ligaments changing, but the knee is starting to kind of break down and starting to become more of a problem, both from a day-to-day standpoint, from the individual's perspective, And as we look at them on x-rays and MRIs, we see that changing as well. And then the late stage of disease is what we're all familiar with here. This is the end-stage arthritis, crippling arthritis. This is when people come and we manage this as any way we know how to get them to a point where they are not in pain and that their level of activity is better. And this is where we really don't want to have to start. So catching these earlier, seeing them earlier, and dealing with these problems earlier is preferred. So the treatments of osteoarthritis of the knee, there's many, and many of them are common sense. We deal in this country with a weight problem. We know it. We see it every day. People are aware of it. There's nobody that sits in my office that's obese or morbidly obese and doesn't know it. How they deal with the problem really is individualized. There are treatments for obesity. There are surgeries for obesity. But obesity does affect your joints. So the weight on the knee is going to accelerate the progression of that, and it is an issue. So weight loss is one measure that many people can be proactive towards and see the benefits of that effect. NSAIDs is a term for non-steroidal anti-inflammatory drugs. These are basically aspirin-like medications that reduce inflammation in joints. It's aspirin, it's Motrin, or Advil, Aleve, things of that nature, and then there's many different prescription strength anti-inflammatories. I might also mention this is the same category or general topic for the supplements, glucosamine, chondroitin sulfate, topical agents, whether they're the joint creams and otherwise. These are things that are used to manage the symptoms of the arthritis on a day-to-day basis. And there's upsides and downsides to all of these, so this is when you are talking to somebody about how you're going to manage it, you need to look at that. Obviously, not everybody can take anti-inflammatory drugs, and so that may not be an option for them. Some people can't take any of the medications, and therefore that becomes a non-option. Physical therapy, it's not necessarily seeing a physical therapist, it's doing exercises, doing activities to kind of try to stay in better shape. Better shape means your joints are more flexible, your muscles are better, you move around better, you're not as limited by the weakness and the stiffness that comes along with the pain. So even though you may have joint pain, therapy or an exercise program is going to be beneficial. Changes in activity. This is some of the hardest things for young or middle-aged individuals to do when they start to have joint problems, is change what they want to do, to go away from an activity that may be detrimental or may be doing harm to their knee and do something different. But it does become reality, whether they're an athlete or whether they're just an exercise enthusiast. At some point they may have to give up running, or they may have to give up tennis, or they may have to give up a sport that's doing harm to their knee. But that is part of the management for arthritis as you go down that road. And then ultimately surgery, which is where we come involved or get involved, is presumably the final step in all this. So when we get to surgery, and that's what we're kind of going to talk about today, we look at this also kind of as a spectrum of what can we do that's minimally invasive, that's what MIS means, minimally invasive surgery, to something less invasive to something more invasive. And knee arthroscopy has been a huge help in sorting out early joint disease, dealing with meniscus tears, dealing with instability problems, dealing with cartilage issues early on. And it truly is minimally invasive. For anybody that's had a knee scope, and I would look in the crowd and guess that probably a third of the people here either have had it or know about it, it involves small incisions going inside the knee and assessing the problem and dealing with it as you can. Now, you're not putting implants in, you're not changing anything other than what's loose or what's a problem inside the joint, but it can help, and that is truly minimally invasive. Partial knee arthroplasty is something that has been around for years. We're going to talk about it in a little different light today, but it's not new. It has been around as long as total knee replacements have been around, and that's 40, 50 years now. So what partial knee replacement is addressing the part of the knee that's worn. As I showed you earlier, that the progression of disease moves from one compartment to another in many people, and sometimes that becomes, it's so bad in one compartment that you can actually replace it. And so this is early on when knee replacements were being designed, people were trying to figure out how to just replace one compartment to the other compartment, putting them together, mixing them and matching them. And that's a thought that largely got abandoned as total knees became more and more successful. So as in anything, the pendulum swings back and forth, whereas years ago there was a certain level of enthusiasm for partial knee replacements. Then it kind of went back to total knee replacements, and for years that became the treatment of choice. And we're starting to see this swing back to doing partial knee replacements, in large part due to efforts over in England by groups that really kept their head down and kept working on fixing some of the problems with partial knees and making them better and more durable. And from that information, and that's a 25 to 30 year period now that they've been really refining partial knee replacements over there, we've learned from that, and we've learned that there's ways to keep the knee from getting worse, and fixing or replacing a portion of the knee may in fact not lead to progression and not lead to that final crippling arthritis that many people used to think was just, you're going to do a partial knee now, but you'll need a total knee later. And that's not necessarily true. So we do owe some credit to the people in Oxford who have pioneered that and who have really written the most about it. And then finally in the surgical option, there's total knee replacement or total knee arthroplasty. And total knee replacements is, like I just said, that has become a very popular procedure. It's 2 to 1 more popular than hip replacements, and it is being done in a younger and younger age group. And one of the concerns we've got, that I have and my other colleagues in this business have, is that we're starting to put total knee replacements in people who may not need total knee replacements. They have arthritis, they have pain, but they don't have a completely worn out joint. And for that reason, we go back to this partial knee replacement, or what we're going to talk about today is this partial knee resurfacing. So, like I said, the total knee replacement is a gold standard for the advanced arthritic knee. It's been proven to be durable. We say 15 years, 90%, but it's probably longer than that. The implants we use today and all of the knee replacement surgeries we do probably last 20 to 30 years. We don't have a good way to know that ahead of time because it's continually changing. The technology allows us better materials, better techniques, and that starts a new clock, and we start tracking that. But the knees that have proven to work well, that have stayed around and been modified very little, have good outcomes, good survivorship at that 15, 20, even 30-year time period. So the downside of the total knee replacement, it is invasive. It is a much bigger surgery, even though it can be applied through the minimally invasive incision that some people have embraced. It is still a more invasive procedure. You're removing more, you're taking out ligaments, you're rebalancing the knee, and for that reason, it is a bigger operation. It clearly requires more recovery. The rehab is difficult for most people. It's long. It can take a year to really adapt to your new knee. So it's not without its downsides. And for many people, it is a hard decision to make. And so they put it off, and they put it off, and they put it off, and they get injections and medications and all the things that we do to try to keep them going. There's a Duke University survey that showed almost all people decline knee replacement or hip replacement when it's first offered to them because they don't want it. Nobody wants to go through that, and you can't blame them if you've known somebody that's done it, other than to say that in the end, they got much better. Now, if we talk about partial knee surgery, which is where we're going to go today, we're going to look at some of the advantages of this. The partial knee allows us to specifically look at one portion of the knee. It is clearly less invasive. We're not removing ligaments. We're not necessarily rebalancing the knee or realigning the knee to the extent that we do in total knees. We can try to get the knee implants in the right position, and in that sense, they perform better. One of the problems with partial knees that I think that we have an answer to with the technique with using the robot is that it's not always easy to get them exactly where you need them to be. So the cutting and the placement of these implants is less precise. I wouldn't say it's not adequate. It works, but it's not as precise as we'd like it to be. And therefore, we've looked for another way to deal with that. This is just the last thing, is just the number of partial knees to total knees is somewhere around 10%, a little less. But of the 600,000 knees that were done in the United States in 2009, only about 50,000 or so were partial knees. And I think we'll see that number changing as we start to change how we think about this. The Makoplasty. I want to give credit to Mako, which is a company that developed and markets the Mako robot. You saw coming in here, they had a table set up with two of the representatives locally who've been very helpful with our transition. The Makoplasty is the term we use for a robotic-assisted partial knee resurfacing or replacement. The terms are somewhat interchangeable, but in reality, instead of replacing a large part of the knee, we're just going to resurface the part that needs to be taken out and replaced. And we do that by using an integrated system that takes a computer model and a navigation system which is real-time capturing the patient's knee in the operating room and correlating that with the computer model and then talking to a robotic arm that we will use to help place these implants exactly where we want them. And this technology allows us to optimally position and balance the knee in ways we've never been able to before. So this picture here is kind of shows the different areas of the knee that we have available to us to replace. The most common is the medial compartment, or the inner compartment of the knee. Probably 90% of arthritis that I see starts in the medial compartment and moves. It may move from here to the kneecap joint, as I showed in that earlier slide. It can sometimes start over on the outside of the knee or the lateral compartment, and sometimes it is just in around the kneecap. I have seen people, it's not many, but there are individuals who have only kneecap arthritis. The rest of the knee looks pristine. But then kneecap arthritis affects their ability to climb stairs, to squat, to kneel. And this is a problem that really to date there has not been a good answer to, because the kneecap is different in almost everybody. So trying to find a way to put an implant in that works for that person has been challenging, and to date really there hasn't been a good option until now. So this is the robotic arm interactive orthopedic system, or RIO as it's referred to in short. And this, like I said, is an integrated system between the computer, which has the information we've given it from a CT scan of the knee, the navigation system, which is talking to the surgical field through optical sensors, and then the robot, which is linked, and once it gets the information it needs, it will steer us in a way that allows us to put these implants exactly where we want them to be. And it involves basically three phases. There's the preoperative planning phase, and that's based on a CT scan and looking at the actual bone anatomy, figuring out what's deficient, what's changed, and what do we need to do to make it look more normal. And this is key. We're trying to restore this particular knee anatomy back to its pre-arthritic state. In a total knee replacement, we're trying to replace it to the state of the design of that knee. So whether it's a Stryker knee or a Zimmer knee or a DePuy knee, that knee design is what we're going to get. What we want to do is we want to restore the knee to its pre-arthritic state, and we want to use implants of different sizes, but we want to put them where they need to be so that they match that. So there's the preoperative phase, which is the planning off the CT scan. There's the intraoperative planning stage, which is where we now have the knee open, and we're going to register the knee or correlate the knee to the CT model. And then once we have the information down, we'll take the knee through an arc of motion and determine what this knee needs now that we got our hands on it to make it move normally. So we restore the anatomy to normal, and now we're going to try to store what we call the kinematics, which means the movement of the knee back to normal. And once we have those two phases out of the way, then the easy part of the operation is the surgery, basically using the robotic arm to go into the knee and to prepare the bone so the implants can be placed exactly where we want them to be. Potential benefits of this, that it is less invasive, even compared to the partial knee replacements that I've done for years. This technique, because we allow the robot and the computer to know where we're going, we're less concerned about having to cut and release more for exposure. So by that sense, it's a less invasive, smaller incision, less is cut, less to heal. We're only getting rid of the arthritic portion of the knee, so we're preserving the other tissue, including the bone, and that's a key issue because in some partial knees, and certainly in total knees, you're removing a bulk amount of bone. You're having to take bone out to put the implants in. So in this sense, we're preserving bone, preserving ligaments, we're preserving cartilage even that is not being used, but we're not taking it out because it's there, we're leaving it alone. So the knee in the end is going to look like it did, minus the fact that these implants are there and are trying to replicate the anatomy as it was previously. And again, the implants are optimally positioned. They're where we want them to be, not just where we think they should be, and then we get an x-ray and go, well, you know, it doesn't look like I really wanted it to. And that has happened in the past, and that's what we've hopefully gotten away from. So the benefits to the individual, to the patient, is I think there's improved outcomes. I think in years to come, the studies, which is in medicine, nothing is real until it's been studied and been validated, and studies have to be designed with proper patient selection, proper criteria, and blinded assessments so that we're not inflicting our bias into the results. Obviously, I stand up here and I'm biased, but studies that show that there are better results with this technology will come in 5 to 10 years once the technology has been around long enough to collect that information. Other benefits, as I said, bone sparing, reduced blood loss. Blood loss is not a big deal for partial knee replacements, but it's a pretty big deal with total knee replacements. And we see very little blood loss with this minimally invasive Makoplasty or robotic knee. And I think the recovery is hands down faster, certainly than a total knee replacement. And in my experience, in the 4 months we've been using it at Baptist, it is a quicker recovery than we saw with the traditional partial knee replacements. There's less scarring, although I'll admit there's still a scar, and there is no such thing as surgeries without scar. Some people scar bad, some people don't, so that hasn't really changed that much. A part of this, I mentioned before that the kinematics or the motion of the knee is preserved, but most importantly to you, or to the person getting it, it feels like their knee. A total knee is not going to feel like your knee. You may be happy that you're out of pain, you may be happy that your knee can move and you can walk, but it's somebody else's knee, it's some engineer somewhere, some technician who assembled it somewhere, and it's their knee and yours. In this case, your knee is still your knee and it feels like it. The ligaments are right, the balance is right, the feedback to the brain is right. Therefore, your activity level is going to reflect that. And we think that I believe people are going to be able to do more, sometimes at risk to themselves, sometimes just more for the sake of doing it, being able to do it, that will benefit them. Less implant wear and loosening, this is another belief. We believe that by lining the components up correctly, by getting rid of the little subtle things that we weren't doing well before, that we can prevent some failures from occurring. Because some knees fail because maybe we didn't get it quite right, maybe the balance wasn't quite right, maybe it was a little too loose. And with this ability, with this technology, we can get around that. And we think, and again, this is presumption, but I think it's based on good science, that we will see less wear, less loosening, less failures. So who's a good candidate for this? Well, we talked earlier about those early stages of arthritis, the early stage, mid-range stages. Those individuals are typically good candidates for partial knee replacement. If they've been through the appropriate evaluations, if they've been treated, it's hard for people to come in and say, my knee's hurt for a week, I need a partial knee replacement. That doesn't happen. But very few people come in with that. Most people come in with years of symptoms that have been managed, and they've had knee scopes, and they've had medications and injections, and they're just not getting where they want to be. And if it's isolated to 1 or 2 places in their knee, then they may be candidates for that. And just to go back, when we showed that picture of the 3 different places in the knee that we can put the implants for partial resurfacing, we can also do 2 of 3 compartments. So we can replace the kneecap in the medial compartment, or the kneecap in the lateral compartment, or even in some cases replace the medial and the lateral compartment, which is getting close to what a total knee does, but the ability to do that is now available to us. You're also a candidate if you're having symptoms of stiffness when you get up after sitting for a while, morning stiffness, just things that come with arthritis. There may be people who have some disease-based arthritis, or rheumatoid arthritis, lupus, many others. They may not be good candidates for this because the knee is not wearing out in the sense that I talked before. It may be wearing out globally because of the disease affects that joint. But those that have this osteoarthritis involving one compartment are the best candidates. And if they, like I said, if they failed the attempts to manage this conservatively. The implant life expectancy, we don't know because the long-term studies just aren't there. But we know that it depends on certain things. The patient's weight, their activity level are two big factors. I have very obese patients who've had joint replacements who put little stress on the knee because they don't do anything. They're just heavy, but they don't do anything. And then I've got some lightweights who are knee abusers. They got there by tearing up their knee, doing things that were damaging or detrimental, and they're going to do the same thing to their knee replacement. So you may have better longevity in somebody who's morbidly obese than somebody who's thin, just because it changes in activity level. Quality of bone stock is important. As people get older, their bone quality is less, and it supports implants less, and that's one of the reasons why any knee replacement or joint replacement in general can fail, is because the bone's not good enough for it. Compliance with doctor's orders. Now, you know, as a physician, the term doctor's orders is pretty commonly used. We don't order anybody to do anything. You know, we make recommendations, we make suggestions, we try to give you information to empower you to do what's right for you. Sometimes we don't agree with each other, so it's confusing. You know, one guy says this, one doctor says that, and you don't know what the right answer is. But I think compliance, understanding the limitations of your joint after a replacement is important. You can't expect too much, but you certainly should expect quality of life to be improved. And if we pick the right patient, we do the right surgery, I think we can accomplish that. Alignment and positioning of components, again, that's getting it right. That's getting it as best we know how to put it in the knee so that it works the best to give you a long, durable outcome, long-term outcome. So the Makoplasty allows us to do that, and with that in mind, we've embraced this technology. We're very enthusiastic about it. The hospital has launched an advertising campaign that has been very visible, and I believe people are hearing about it. It is something that has been done in other hospitals around the country, and we are starting, and we're happy with it, and I'm very pleased to be a part of that. I have three other partners right now in our downtown office, Drs. Tandrin, Drs. Lucie, and Pajadas, who are also doing this, but I think we're going to be seeing more of our surgeons embrace this technology, and we'll see more doctors around town embracing this as time goes on. So the Baptist has set up a number to call in if you have any questions or you want an appointment for an evaluation, and it's simply 904-202-KNEE, and that has been set up to aid you in getting in to see people if you want to talk about it or get information to you. So the last part I want to do is to show a little 3 or 4 minute video that Mako has put together that kind of brings everything I said together, and I think does a real nice job of filling the gaps that I've had here.
More than 15 million people in the United States suffer from osteoarthritis of the knee. Of these 15 million people, there is a large portion of the population diagnosed with early to mid-stage osteoarthritis, like Marjorie. Depending on where the arthritis is located in your knee, Makoplasty partial knee resurfacing may be right for you. The knee is made up of 3 compartments: the medial, lateral, and patellofemoral. Osteoarthritis typically begins in the medial compartment or on the inner side of the knee.
Nice to meet you. Nice to meet you.
During the early stages, you may have to limit some daily activities. You are usually able to pinpoint exactly where the pain is located simply by pointing to it. If pain persists, the physician can inject the site with a corticosteroid to reduce inflammation and manage pain, or prescribe anti-inflammatory medication. But as the disease and pain progress, these treatment options may no longer be effective.
So you can go ahead and sit up.
During early to mid-stage osteoarthritis, Makoplasty, a minimally invasive partial knee arthroplasty, could be a successful treatment option. During Makoplasty, the diseased portion of the knee joint is removed and healthy bone stock and tissue are spared. Once the disease progresses into the patellofemoral compartment of the knee, partial resurfacing of both the medial and patellofemoral joints may be an option, Otherwise, your only surgical option is total knee arthroplasty, during which large amounts of healthy tissue and bone must be removed along with the diseased portions. And this can result in a significantly longer recovery time following surgery. Today, there is new hope for adults living with early to mid-stage osteoarthritis. There's Makoplasty. Makoplasty is a minimally invasive procedure that's enabled by a robotic arm system that assists the surgeon in achieving optimal resurfacing and placement of the implant. Each procedure begins with a pre-surgical CT scan of the patient's knee. This information is then digitally scanned into the Mako system for the surgeon to use in making a custom pre-surgical plan. This plan details every step of bone preparation, resurfacing, and implant positioning during surgery. This careful planning facilitates the most accurate positioning and precise alignment of the implant possible. During Makoplasty, the bone is minimally resurfaced, saving valuable bone stock and sparing tissue. The pinpoint precision and consistency afforded by the robotic arm system that assists the surgeon during the procedure provides a more natural feeling and functioning knee following surgery. Because Makoplasty facilitates more precise placement of the implant and spares healthy bone and tissue, Makoplasty patients may experience a more rapid recovery and return to normal activities than with traditional knee surgery. Marjorie left the hospital only 72 hours after her surgery and returned to normal activities shortly thereafter. In some cases, you may go home even earlier, or in the same day if you undergo Makoplasty in an outpatient facility. For many, like Marjorie, the answer is Makoplasty, partial knee resurfacing.
Okay, so I think we have a few more minutes for questions. I'm going to follow the microphone this time. Okay?
If you've had both of your knees replaced and they have to be replaced sometime in the far future, is there a problem with that?
Yes. The best success you can have with a knee replacement, whether it's what we're doing with this partial resurfacing or any knee replacement, is your first go at it. And anything afterwards, done for whatever reason, whether it's failed, whether it's not lined up right, whether it's broken, is not going to be as good as the first.
Mine are 9.5 and 9 years old, and they're working wonderfully.
Right.
Dr. Lucie did both of them, and they were wonderful.
Right. And that's the whole idea, is we want to get the best results we can from the beginning. You can't argue with a good, with a well-done and a well-functioning total knee, but you may not need a total knee in some cases where in the past that's what's been performed. Yes, ma'am.
The main problem with my knee is the tracking. The tracking, something is wrong with the tracking. So can you fix that with this?
When you talk about tracking, then presumably we're talking about your kneecap.
Kneecap
because that's the tracking issue. And kneecap tracking is a unique problem in and of itself. And in order to, you can't just replace a kneecap joint to restore kneecap tracking. You literally have to put the implants where they don't need to be. So you have to fix the tracking.
That's my question, because I'm wondering if you're going to replace it exactly the way it is now, then the tracking still won't be right.
No, you have to correct the tracking. You have to do a corrective procedure, which doesn't involve the robot. It's basically a realigning and repositioning the kneecap so it tracks normally. Yes, ma'am.
I read...
I'm following the microphone, so when the microphone comes to you, we can hear you.
I've read in the past that they were doing research on growing your own cartilage to be used in the implants. Where's that procedure at this time?
The best I can tell you, because I'm really not on the research end of things, is from what's available today for arthritic joints, which is worn out degenerative joints. There is no cartilage substitute available. there are procedures that we do for cartilage injuries in an otherwise healthy knee to try to grow cartilage cells in an area that they can be housed and be contained. The problem with the arthritic knee is that it is not just the cartilage, it's everything else around it, and trying to regenerate healthy cartilage there has not yet been successful that I know of. Where's the microphone?
How much would this type of procedure cost, and does Medicaid and Medicare pay for this type of procedure?
Yes. Oh, microphone. Wave at me.
Go ahead.
Okay, go ahead.
Yes, sir. What's your anticipated surgical volume through the rest of this year, and what are the centers of excellence around the country? What kind of volume are they doing?
I don't know the answer to the second question because I don't keep up with hospitals that have been deemed centers of excellence in terms of their volume. And I can't even tell you what our volume, expected volume is. If we're really true to patient selection, this should apply to about 10% of people who come in who are candidates for knee replacement. And in our hospital, I think we did 400 or 500 joints last year. So you're talking 50 or 60 joints in the year that we expect to apply this to. I think the number will go up a little bit because we're looking a little bit more at people that may not be candidates for total knees, and that may change our skew a little bit. But honestly, I don't know what other hospitals are doing. Yes,
when you are being evaluated for the knee as to where you are in this point of time, how do you evaluate that? By x-ray only, or do you go ahead and do the CT scans prior to?
No, we base the decision to do surgery on predominantly x-rays and clinical findings. So we can see well enough what we need to see. There may be, depending on what's been done in the past, there may be a role for MRIs to assess the cartilage and things called the meniscus to see if they're part of the problem, to know that we're not getting in and over-treating a knee that may be treated simply some other way. But once we know what we're doing based on the plain x-rays, clinical exam, then the CT scan is in no way a diagnostic tool. It is a planning tool. So when we get a CAT scan, we're not making a different decision. We're taking the information that it gives us and we're making the plan for the surgery. So it's a little different in how we're utilizing the CAT scan technology. Yes, ma'am.
The question I have is about insurance. What is accepted? Regular insurance, TRICARE, Medicare?
Well, I mean, the surgery, this procedure is a traditional accepted surgical replacement of the knee. So nothing is done here outside the normal. There's no additional billing for the use of the robot. It's just a tool that we use to put this in. So there is no special exception or special authorization we have to get. Medicare is starting to look a little more closely at preoperative criteria being met, and they've come back and really dictated to us and really to the hospitals, because that's where they have their strength, is they can deny or they can retract payments if they think that a knee replacement was done and somebody hadn't had the appropriate diagnosis, hadn't been treated conservatively, hadn't gone through a therapeutic trial short of surgery. And in that sense, and I think to be good physicians, we should always do that. It really should never be the discussion when you first start talking about somebody's knee surgery, unless they've been down this road. We're getting people who've been around and around and around, and they land here and they're ready to go, but they've been through all the prerequisites for conservative care. Yes, ma'am.
Since this is a new type of surgery, has anyone requested that the surgery be done on both knees during the same hospital stay? And if so, would you recommend this,
Yes and no. They have requested it. Every now and then somebody comes in and they're brave enough and they're determined enough to want to have both knees done at the same sitting. It can be done. We have not done one that way yet, but I have one that's coming up that was so determined when I told her I'd really rather not because the complications are a little greater. She scheduled them a week apart. And at that point, if you're going to go week to week, it might make sense to do them both because she hasn't done herself any favor by waiting a week. She's going to have to go through both knees recovering. But I think it's possible. There's a little bit of a, just how we set up when we're working on one knee, and then we have to kind of reset up for the other. But that's no different than doing total knees at the same time. It's really not a good idea to do that unless there's a really strong reason to do so, because there is greater risk to the patient. The anesthesia is a little more complicated. There may be a little more blood loss. There may be a little more postoperative problems. Wound healing may be more compromised. And obviously the recovery is much tougher. But it can be done. Yes, ma'am.
Can you tell me how extensive the evaluation appointment is? Is it mostly a consult appointment, or do you start testing at that evaluation?
Well, in our world, in orthopedics, testing comes down to, x-rays and hands-on. So, it's a history, talking to you, it's a physical exam, and it's looking at x-rays, either those that are brought in or those that we get in the office. There's really not blood tests involved with the decision-making here. There may be some reviewing, people have had scopes. We may want to look at what was done in the previous arthroscopies. Some people come in with MRIs, want to look at those. But the actual assessment process is fairly streamlined. I probably spend more time just talking about the procedure in these appointments when they've come in than I have really looking at that person's knee or those x-rays. That's the easy part for me.
Take one more question.
Okay.
Yes, ma'am.
You have a patient. You've decided that surgery is needed. How do you determine now if it's a total knee replacement is needed or a partial? What's the steps?
Well, some of it is what they can tell me. Where does it hurt? Kind of characteristics of the pain, what causes it to hurt, because then I can start to break down where the problem is. Is it the kneecap issue, or is it more one-sided joint? Or in some cases, people come in and say, my knee hurts. Where does it hurt? It hurts all over. Well, in that case, they're probably not a good candidate for a partial resurfacing because we're going to take away one part of that knee pain and maybe leaving everything else there. So it's what they tell me, it's what their x-rays look like. I mean, the x-rays don't lie. If the disease is there and it's long-standing and it's moved to all three parts of the knee, it's going to show up. Sometimes we will get in and look. We may be on the fence. Well, it hurts on one side, but it shows a little arthritis on the other. We may look in the other side of the knee when we open the knee and assess the cartilage there. Sometimes we'll go in to do a knee arthroscopy to address a torn meniscus. We find that they've got high degree of wear on one side of the knee and a little bit on the other side of the knee. Those are things that help me decide where that person's going to fit best. All right. Well, I hand it off to Jonelle now, and I want to thank you.
Dr. Crenshaw will be available for questions. 3 quick things. You have on your table the survey from Channel 7. Please fill that out. You also have an appointment form that has other checks if you'd like further information from Baptist Health and or more information from us regarding Mako and Dr. Crenshaw. We thank you for coming, Baptist Health and Jacksonville Orthopaedic Institute and WJCT. We work as a team for these. If you have friends that are interested that could not make this luncheon today, as they mentioned, we're doing another one in May. It's on joionline.net, our website. It's also on Channel 7, and it's also on the Baptist Health. I'd like to thank our Mako representatives here, which have information for you, and also the Baptist Joint Replacement Center. There's information on the back table if you'd like to take some more. Thank you very much for coming and spending your time with us today.